In this video, we are going to learn about the physiology of circulation. There are certain terms we need to know what these mean. These are flow, pressure, and resistance. Let's go over the definitions of these terms. So blood flow, it is the volume of blood flowing through vessel, organ, or entire circulation in a given period of time. Blood flow, it is measured in milliliters per minute, and it is equivalent to cardiac output for the entire vascular system. Overall, it is relatively constant when at rest, but at any given moment it varies at individual organ level based on the need. Now, what is blood pressure? Blood pressure, it is the force per unit area exerted on the wall of the blood vessel by the blood. It is expressed in millimeters of mercury, and it is measured at systemic arterial blood pressure in large arteries near the heart. Pressure gradient within the vascular system, it provides the driving force that keeps the blood moving from higher to lower pressure areas. So the blood pressure, higher pressure areas are there closer to the heart, and lower pressure areas as they move away from the heart. Another term we need to know is resistance. What is resistance? It is opposition to flow. It is the measurement of amount of friction which the blood encounters with the blood vessels. Generally, it is more in the peripheral or the systemic circulation. So that's why we use that term total peripheral resistance, that how much resistance is to the flow of the blood. And there are three important factors which affect resistance. So this photograph, I took it from your Pearson text, and it explains the resistance very well. Now just consider this thick milkshake, and now just imagine if this is a thick milkshake. Is it more difficult to move this thick milkshake in a tube, or if it was water, it will be easier for the water to move? And then just imagine if it will be easy for you to drink with this wide diameter straw, or with this thin small diameter straw. So if you drink it with the wide diameter straw, it will be easier to drink. And if you use this thin and long straw, it will be more difficult to drink this thick liquid. But if I replace it with water, then it becomes easier for me to drink. So these are the three factors. The viscosity. Viscosity is the thickness, and then the total blood vessel length. It affects the resistance. Greater the vessel length, greater is the resistance. And then the blood vessel diameter. If the diameter is wider, it is easier for the blood to move in the wide diameter vessel compared to the thin diameter vessel. So these are the three factors which affect the resistance. Blood viscosity, it is the thickness or stickiness of blood, and it is due to formed elements and plasma proteins which are present in the blood. We know that blood is made up of plasma, and then it has formed elements. The formed elements include the three types of cells, and then there are also plasma proteins present in the blood. So these are the things which make the blood thick. And the greater the viscosity, the less easily the molecules are able to slide past each other in a vessel. Just imagine that thick milkshake. It is difficult for that thick milkshake to move in the vessel compared to a thin liquid. Increased viscosity, it is equal to increased resistance. And blood viscosity, it is relatively constant. Under normal conditions, the blood viscosity, it is constant. Like, it is not a factor which can be immediately changed. It does change in certain diseases. For example, in polycythemia, we have increased number of RBCs, and in anemia, we have decreased number of cells. So in the above condition, the blood becomes thicker, and in anemia, it becomes thinner. But under normal conditions, viscosity is not a factor which changes. It remains constant. Then the other factor which affects the resistance is the total blood vessel length. So the longer the vessel, the greater the resistance encountered. And this also stays constant. Blood vessel diameter, it has the greatest influence on the resistance, and it can be changed frequently. And when it is changed, the resistance, it alters, it also changes. For example, let me draw. If this is our normal lumen of the blood vessel, this is the diameter of the blood vessel lumen, and then certain factors act upon it and they make it bigger, and then certain other factors act upon it and then they make it smaller. Now we can see that in this there will be less resistance to the flow of blood, whereas over here there will be more resistance to the flow of the blood compared to the normal vessel. So this is how altering the diameter of the vessel, it alters the resistance. The resistance becomes greater or smaller, and resistance varies inversely with the fourth power of the vessel radius. So for example, if the vessel radius is it was 1 before and then it becomes 2, so it will be 2 into 2 into 2 into 2, which will be 16. So the resistance will increase 16 times if the radius is changed from 1 to 2, because it is but on the fourth power of the radius, it is inversely proportional to the resistance. Small diameter arterioles are major determinants of peripheral resistance, because we already learned before that arterioles are the vessels which are also known as resistance vessels. So at the level of the arteriole, that is where the maximum resistance is present, and many factors they affect the arterioles. Radius changes frequently in contrast to larger arteries that do not change often. So arterioles, their radius, it changes more frequently. And then there is a laminar flow. What is laminar flow? Laminar flow is this. For example, if I draw this blood vessel, the fluid which is closer to the vessel wall, it will be sticking to the vessel wall, so it will be moving slower. So the blood which is closer to the wall of the arteriole, it is moving slower compared to the fluid in the middle. It is going ahead of the fluid on the side. So this is known as lamellar flow. And abrupt changes in the vessel diameter or obstacle, such as fatty plaques from the atherosclerosis, dramatically increase the resistance. And then the flow becomes turbulent and more resistant. For example, consider this is again a vessel wall. I don't want to make it um, unstraight. So this is a vessel wall, right? So what happens that the flow was going like this. It was laminar. Then in this vessel wall there is an atherosclerotic plaque. So these are like fat deposits in the vessel wall. And what do? They are just present, and they are an obstacle to the blood flow. Now the blood which is coming here, it is kind of becoming turbulent, and it can even bounce back or it can go this way. So there will be some turbulence, and that turbulence, it will hinder the blood flow. So this is turbulent flow. Or the other reason, other pathway by which it can become, for example, the vessel is constricted from here, right? There is a constriction because of some reason this part is constricted. Now there can also be a turbulent flow. Some of the fluid will be going back, some will be trying to move forward, so there will be turbulence. This will increase the resistance. To conclude everything, three important sources of resistance are blood viscosity, total blood vessel length, and then blood vessel diameter. It is variable. Arterioles are the primarily responsible for the resistance, and the laminar flow is less resistant than the turbulent flow. Now let's see what is the relationship between the flow and the pressure and the resistance. We went over the definitions. Now blood flow is directly proportional to the blood pressure gradient. Okay, the more is the blood flow, the more will be the blood pressure gradient. What is blood pressure gradient? It is the difference in the hydrostatic pressure of the blood in the arteries. So if the pressure gradient increases, blood flow speeds up. Okay, so blood flow is inversely proportional to the peripheral resistance, right? So if resistance increases, blood flow decreases. So F is the blood flow. It is directly proportional to the pressure gradient and inversely proportional to the resistance. And resistance is more important in influencing local blood flow because it is easily changed by the altering blood pressure, blood vessel diameter, like we already saw. Now let's see the pumping action of the heart. It generates blood flow, and then this is the blood flow which goes into the vessels, and the pressure results when the flow is opposed by the resistance. Systemic pressure is highest in aorta and declines through the pathway, and the steepest drop it occurs in the arterioles. So in the aorta, we have a systolic blood pressure and we have a diastolic blood pressure. This upper line is the systolic pressure, which happens when the heart it contracts and pushes the blood into the aorta. When heart pushes blood into the aorta, because of the kinetic energy imparted to the aorta it distends, and we have a systolic pressure of 120 millimeters of mercury in the adults, normal adults. And then when the heart relaxes, we get the diastolic blood pressure, which is 80 millimeters of mercury. And this difference between the systolic blood pressure and diastolic blood pressure is known as pulse pressure. So what is pulse pressure? Pulse pressure is systolic pressure minus diastolic pressure. So in this case, if I take out 80 from 120 millimeters of mercury, it will be 40 millimeters of mercury. And this pulse pressure, this is responsible for the pulse we feel. When we go to the doctor feels your pulse. So there is a throbbing felt in the artery. When we press the artery against the bone, we can feel the throb of the artery. That is known as pulse. And this pulse pressure, it decreases as we move down towards this part of the circulation. As you can see that this pulse pressure, it is present in the aorta, in the arteries, and then in the arterioles. By the end of the arterioles, it is gone. And then we also need to see over here that arterioles are the vessels in which maximum resistance is present. That is why the blood pressure or the blood flow, it decreases maximally here in the arterioles. For example, consider this column. When it is coming in the arterioles, it is at 80 and maybe 85 over here, but as it is goes down the arteriole, it is 40. So it has decreased by 40 millimeters of mercury in this graph. So arterioles are the resistance vessels. This is where the flow it decreases and they provide the maximum resistance. Arterial blood pressure or blood pressure, it is determined by two factors. The elasticity, it is the compliance or the distensibility of the arteries closer to the heart. So one factor is elasticity of the arteries close to the heart, and the second factor is the volume of blood forced into them at any time. Blood pressure near the heart is pulsatile and it rises and falls with each heartbeat, like we went over in the previous slide. So systolic pressure, it is the pressure exerted in the aorta during ventricular contraction, and it is about 120 millimeters of mercury in normal adults. And diastolic pressure is the lowest level of the aortic pressure when the heart is at rest. Pulse pressure is the difference between the two, and pulse is the throbbing of arteries due to difference in pulse pressure which can be felt under the skin. So I already went over these terms. Now let's see what is mean arterial pressure. Pressure that propels the blood to the tissues is known as mean arterial pressure. And pulse pressure, it becomes smaller and smaller as it goes towards the end of the arterial tree. Our heart, it spends more time in diastole. So it is mean arterial pressure. It is not simply I take the mean of the systolic and the diastolic pressure. I add both and divide by 2, and I get mean arterial pressure, because our heart, it spends more time in the diastole. So the pulse pressure, mean arterial pressure, it is calculated by adding diastolic pressure plus 1 over 3 of the pulse pressure. This is how we get our mean arterial pressure. This is the formula for our mean arterial pressure. It is diastolic pressure plus 1/3 pulse pressure. Now, for example, in this example, the blood pressure is 120 over 80, so pulse pressure is 40. So our mean arterial pressure, it will be 80 plus 1/3 of the 40, and which comes about to be 93 millimeters of mercury. And pulse pressure and mean arterial pressure, they both decline with increasing distance from the heart, like we saw in that chart. Arterial blood pressure and pulse, they are very important when a patient goes to a doctor's office. First of all, his or her vital signs are checked, and in those vital signs, pulse and blood pressure are included. So when a patient comes to a doctor's office, the doctor gets its pulse checked, blood pressure checked, respiratory rate, and body temperature checked. And how do we take a pulse? We take usually it is a common practice uh, to notice the radial pulse. It is taken at the wrist on the side of the thumb because the radial artery is present laterally, and then we press near the wrist. If you do it right now, you will be able to feel your radial artery pulsating. And there are different pressure points where the pulses can be felt. Those pressure points are the areas where arteries are close to the body surface. So these are the different points in the body where the pulse is most easily palpated. If you want, you can try a few spots. Just press gently, a little firmly, and you will be able to feel the pulse. After taking the pulse, the doctor takes the blood pressure or asks the nurse to take the blood pressure. And the equipment we use to take the blood pressure is known as sphygmomanometer. A cuff is wrapped around the upper arm, and then air is pumped into the cuff, and then slowly the pressure is released. And when we start hearing the sounds, we call those, we note down that as the systolic blood pressure. And when those sounds, they disappear, we note down that as the diastolic blood pressure. And how do we hear the sound? We hear the sound with the stethoscope. That stethoscope, it is placed at the brachial artery and slightly pressed. These sounds are known as sounds of Kortokov. So we are talking about arterial blood pressure, which in everyday term is called blood pressure only. So there is also capillary blood pressure. Let's see what it is. It ranges from 35 millimeters of mercury, beginning at the capillary bed. So at the beginning of the capillary bed, it is 35 millimeter of mercury, and as it goes towards the venous end of the capillaries, it becomes 17 millimeters per mercury at the end of the bed. Low capillary pressure is desirable because of two reasons. High blood pressure would rupture the fragile, thin-walled capillaries because capillaries are very thin. It is only a layer of endothelial cells resting on the basement membrane. So if the pressure is too much, these capillaries can rupture. And secondly, the capillaries, we know they are very permeable because all the gas exchange and the nutrient exchange and the waste product exchange, it happens in the capillaries. That is why the capillaries, they are very permeable to perform that function. So low pressure forces, they filtrate into the interstitial spaces. So if the pressure is increased, more of the stuff from the capillaries, it will go into the interstitial space. So that is why we do not want too much blood pressure at the level of the capillary. Now let's see what is venous blood pressure. Venous blood pressure, it changes little during the cardiac cycle. Small pressure gradient is present in the venous system, only about 15 millimeters of mercury. So it means if a vein is cut, low pressure of venous system causes the blood to flow out smoothly. But if you accidentally during surgery, the surgeon cuts an artery, you will see a spurt of blood coming from that artery. Sometimes it can go up till the ceiling. So low pressure in the venous system, it is due to cumulative effect of the peripheral resistance. Energy of the blood pressure is lost as heat during each circuit. And low pressure of venous system, it requires adaptations. What does that mean? That because the pressure in the venous system, it is low, so we need certain adaptations to make sure that the blood is going to go back to the heart. And what those adaptations are: muscular pump, respiratory pump, and the sympathetic venoconstriction. I will go over the sympathetic venoconstriction first of all, and then I will talk about the respiratory pump and the muscle pump. So for example, this is a normal vein. This is the normal diameter of the vein at which it is present in the body. And then this is a vein when sympathetic stimulation happens and it constricts. And then this is a vein where sympathetic stimulation is absent and it vasodilates. Now you can imagine that when this vein, it turns into this size, the blood, it is pushed back into the blood. So this is one of the factors how sympathetic venoconstriction, it causes the movement of the blood back to the heart. Remember, our veins, they have valves, so blood cannot backflow. It cannot go down unless and until that person is getting sick and those valves are being destroyed. So this is what happened. And also I want to put some stress on another point, that when these veins dilate, our veins, they act as blood reservoirs. 60% of our body's blood, it is in the venous system, so it acts as a reservoir for the blood. So the third point we discussed, which helps the venous return to come to the blood, because venous system is a low pressure system, so blood is not moving due to the pressure difference, because the pressure difference is very low, whereas in the arterial system it is moving because of the pressure difference. So this sympathetic venoconstriction, it causes the blood to move back. And now let's look at the other two, the muscular pump and the respiratory pump. So how do our muscles, they help in the venous return? So when the muscles contract, they cause the blood to move up. Now remember, these are the venous valves, so they will not allow the blood to move down. But when blood is coming from here, the valve will open and it can come through here in the middle. Pretend this line is in the middle. And similarly, it goes up. See here, the valve is open. It can come through here, but it cannot come down. If it goes down, these valves, they close. So this is how our muscular system, it helps in the return of the venous blood towards the heart, and this is known as the muscular pump. And what is respiratory pump? Respiratory pump is that when we inspire, when we inhale, when we take the breath in, there are negative pressures in the chest. Those negative pressures, they pull the venous blood up. They help in return of the venous blood towards the heart. So these are the three factors which help the venous return to the heart: the muscular pump, the respiratory pump, and the sympathetic. Now let's go over the regulation of blood pressure. So far we discussed that arterial blood pressure is the blood pressure we commonly used, and then we discussed that there is a systolic pressure, then there is a diastolic pressure. The difference between the two is known as the pulse pressure, and because of this pulse pressure we feel the pulse, which we can record. And then we went over the method of how do we record the blood pressure, and then we went over that this is the arterial blood pressure actually which we are talking about. In the capillary pressure, the pressure is very low. It is from 35 to 17 millimeters of mercury, and we want to keep it low because the capillaries, they can rupture, and also too much fluid can go into can squeeze out of the capillary bed into the interstitial fluid. And then we discussed our venous system. It is a low pressure system. The pressure gradient is very low in the venous system, so the pressure is not the main factor which is causing the blood to return to the heart. So venous system has some adaptations, and those adaptations are the muscular pump and the respiratory pump and the sympathetic venoconstriction. These these things, they aid the venous blood from coming back towards the heart. Now we are going to see at the regulation of the blood pressure. So blood pressure, when I say blood pressure, this is arterial blood pressure which we are talking about. So this is what we commonly use blood pressure for it. When I say my blood pressure is like 140/90, it means this is my arterial blood pressure. Okay, so what are the factors which help us to regulate the blood pressure? So there are four organs. So first of all, heart, right, which makes sense. Then blood vessels, and then there are two organs, kidneys and brain. They help to regulate the blood pressure. So we will see how they do it. Now let's see what are the three main factors which regulate the blood pressure. They are cardiac output, total peripheral resistance, and now remember that this total peripheral resistance, it is primarily due to the arterioles, because arterioles are the vessels where we saw that the blood pressure, it dropped from 80 to 40. So there was almost 40 millimeter per mercury drop in the because of the resistance in the arterioles. And arterioles, they can readily constrict and they can readily dilate. They are the vessels which are influenced by systems in the body, and those systems can cause them to dilate, and they can cause them to constrict. And then the third factor is the blood volume. So these three are the factors which if regulate the blood pressure. And blood pressure varies directly with cardiac output, total peripheral resistance, and blood volume. Now see, in the previous slides we said that blood flow is equal to the pressure difference over the resistance. Okay. Now the blood flow, what is cardiac output? It is the total blood flow each minute the heart pumps out. So our flow is the cardiac output. We have replaced the flow with the cardiac output. Now cardiac output, it equals to the pressure gradient and the resistance. And if we rearrange, the pressure gradient is equal to cardiac output into resistance. Now this our pressure gradient, this is mean arterial pressure. Mean arterial pressure, we calculated, and we said we cannot just add systolic and diastolic and divide it by 2 to get the mean arterial pressure. Mean arterial pressure is systolic pressure plus 1/3 of the diastolic pressure, because diastole is longer than the systole. So now our formula, it becomes mean arterial pressure, okay, is equal to cardiac output into resistance. And now remember, cardiac output, we discussed that cardiac output is equal to stroke volume into heart rate. So I have put mean arterial pressure in place of the delta P, the pressure gradient, and then the cardiac output is equal to stroke volume into heart rate, and then this R is our resistance, or the TPR, we will take it. So anything that increases stroke volume, heart rate, or resistance will also increase mean arterial pressure. Okay, and so stroke volume, we know it is affected by the venous return. We discussed it when we were talking about cardiac output. What are the factors which affect the stroke volume? So any factor that increases stroke volume is going to increase the blood pressure. And stroke volume is primarily, basically, it is, remember the Frank-Starling law. The Frank-Starling law, it stated that the more venous return, the more there will be end diastolic volume. End diastolic volume is the one that stretches the resting cardiac muscle. And then more end diastolic volume, the stretch will be more. As a result, the stroke volume will be more. Stroke volume is the blood ejected by the heart with a single heartbeat. So this is more end diastolic volume, more stroke volume. Then heart rate, we know heart rate, it is primarily monitored by the autonomic nervous system. There are medullary centers. There is a cardio-acceleratory center and a cardio-inhibitory center, and both of these, they affect the heart rate. And then we will learn about a new center which also affects the heart rate, heart rate and the vasoconstriction. And then there is resistance. Resistance, it is affected mostly by the vessel diameter. Now let's go on to the next slide. So we will see the regulation of blood pressure under short term and the long term. And in short term, first we will see what are the neural controls. Okay, what are the controls coming from the nervous system? That can be central nervous system or the autonomic nervous system. Then we will see what are the effects of hormones on the short term regulation, and then we will see that how the blood pressure is monitored long term. And in this, kidneys, they play a very important role in the long term management of blood pressure. Now let's go over the factors which increase the mean arterial pressure. So mean arterial pressure, it is our blood pressure, because we are taking mean arterial pressure, the mean of the systolic and the diastolic pressure together. So we, instead of having 120, 180 figures like this, we are taking mean arterial pressure. So mean arterial pressure, it is let's see, it is dependent, move from back down. So mean arterial pressure, it is dependent upon cardiac output into resistance, or the TPR, total peripheral resistance, is equal to mean arterial pressure. Remember, delta F is equal to cardiac output into R, right? Now cardiac output, it depends on stroke volume and the heart rate. If there is increased stroke volume, increased heart rate, cardiac output will be more, mean arterial pressure will be more. And then we have resistance on the other side, and resistance, if the diameter of the blood vessel decreases, or if the viscosity increases, or if the blood vessel length increases, the resistance increases. And now we know these two factors are relatively constant, but the diameter of the blood vessel, it can be changed very easily in the body, or every day, every moment it can be changed. So this is where the which is a variable, and it can be frequently changed. So it makes it very important, the diameter of the blood vessels, especially the arterioles. So when the diameter is decreased, total peripheral resistance is increased, and the mean arterial pressure will increase. Let's go over the short-term neural controls which help maintain the mean arterial pressure. So mean arterial pressure is maintained primarily by altering the blood vessel diameter, which we spoke about already. And diameter, because when the diameter is increased, the resistance is decreased. For revision, resistance is inversely proportional to the fourth power of the radius of the vessel. So when we decrease the radius, the resistance increases, and vice versa. So for example, consider a person who for some reason they have a decreased blood volume. Maybe they got in some accident and they lose some large amount of blood, and now their blood volume has decreased. So now what is the body going to do? Because of that it has to maintain the arterial pressure. So what does the body do? The neural mechanisms, they send signals to the vessels, especially the arterioles, and then these vessels, they constrict. What happens when they constrict? When they constrict, the resistance increases, and that resistance, it increases the blood pressure, or the mean arteriolar pressure, which we are calling it in this example. So this constriction, it increases the resistance, it increases the resistance, and then because our resistance, it increases the blood pressure in return. But in certain organs, this vasoconstriction does not happen. In the brain and the heart, the blood supply is conserved. So this vasoconstriction and vasodilatation, it can be used to alter the blood distribution to the organs in response to specific demands, because the body wants to keep these two organs specially alive. So there is vasoconstriction in the rest of the body, and the blood is being conserved to go to these organs, and this vasoconstriction, it raises the mean arterial pressure. So what are these short-term neural controls, and how do they act? These neural controls, they operate via reflex arc, and they involve cardiovascular center of the medulla, and then there are some structures which are known as baroreceptors, And then we have another structures which are known as chemoreceptors. And then there are some higher brain centers which are involved. Let's go over these structures of the which are responsible for the neural control. So we have cardiovascular center. Cardiovascular center, it is present in the medulla of the brainstem. So cardiac center is present in the medulla of the brainstem. And then we have two cardiac centers. We know we have cardiac centers which are cardio inhibitory, and then we have cardio acceleratory centers. We also talked about these centers when we were discussing the heart rate in the cardiac output chapter. Okay, and then we have another center which is known as vasomotor center. Vasomotor center, it sends steady impulses via sympathetic efferents. Those efferents are called vasomotor fibers, and those fibers go to the blood vessels, mainly to the arterioles. And what do they do? Remember, sympathetic always causes venoconstriction. So they venoconstrict them, or in other words, they reduce the diameter of the arterioles. And our vessels, they are under continuous moderate constriction called vasomotor tone. Vasomotor tone, it varies from organ to organ. It is more in the skin and digestive system than as compared to the skeletal muscles. And increase in sympathetic activity increases vasoconstriction and raises the blood pressure. Cardiac center, they receive input from the baroreceptors, chemoreceptors, and the higher brain centers. So these are the three cardiac centers. Cardio inhibitory, we can tell that the cardio inhibitory, they decreased the heart rate. They are from the parasympathetic, and parasympathetic uses the vagus nerve. And then cardio acceleratory, these are the sympathetic, and they come from they go to the ganglions and cervical ganglions in the sympathetic chain, and they basically primarily they inhibit the parasympathetic input. In this way they increase the heart rate. Then we also have a vasomotor center which is sympathetic, and its fibers are known as vasomotor fibers, and they are responsible for a vasomotor tone. So in resting conditions, our vessels, they have a vasomotor tone, which is because of the sympathetic activity. Now let's see how these cardiac centers, they are affected by baroreceptors, chemoreceptors, and the higher brain center. First of all, let's see what are the baroreceptors. Baroreceptors, they are special receptors which can detect the pressure changes. And where are they located? They are located in the carotid sinus. So this will be common carotid artery. Common carotid artery divides into internal carotid and external carotid. So at the beginning of the internal carotid, we have a carotid sinus. This is where baroreceptors, the cells of baroreceptor, they are located or situated. Then another place is in the arch of the aorta. In the arch of the aorta, we also have baroreceptors. They are present. And what is the job of these baroreceptors? They can detect the pressure change. So what happens when the mean arterial pressure is high? It means we have high blood pressure. Increased blood pressure stimulates the baroreceptors to increase input to the vasomotor center. And then they inhibit vasomotor and cardio acceleratory centers. And they stimulate the cardio inhibitory center. And this results in decreased blood pressure. So let me go over this again. So when there is high blood pressure, both of these, they send lots of signals. They send lots of signals, and those signals, they inhibit the cardio acceleratory center, and they inhibit the vasomotor center, and they stimulate the cardio inhibitory center. And in this way, they decrease the blood pressure. Now let's see in a little more detail how the baroreceptors, they decrease the arterial pressure. So they act by two methods. One is the vasodilation. They're acting on the veins, on the vessels, right, on the arteries and the veins. And the second, they will act on the heart. In this slide, let's see what they are doing at the level of the vessels. So they cause vasodilation. How do they cause vasodilation? So let me repeat again. We have a vasomotor center. That vasomotor center is under the sympathetic control, and then at this vasomotor center it sends vasomotor fibers to the vessels. Because of these vasomotor fibers, under the sympathetic stimulation, our vessels at resting stage, at normal stage, it means right now they have a vascular tone, so they are present in this form. And when that vascular tone it is decreased in the arterioles, it causes vasodilation. So when arterioles they vasodilate, the peripheral resistance it decreases, and hence the mean arterial pressure it falls. And when this vasodilation it happens in the veins, when the veins dilate, we call it venodilation. It shifts the blood to venous reservoirs, which decreases the venous return and the cardiac output. Like I said before, our veins, they are the reservoirs for the blood. 60% of our blood is in our venous system. So just imagine when these veins dilate, they can even keep more blood in them and prevent it from returning to the heart. And as we went over, according to the Frank-Starling law, when there is more venous return, there is more end diastolic volume. When there is more end diastolic volume, there is more stretch of the cardiac muscle. That increased stretch of the cardiac muscle, it increases the stroke volume, because now the heart is contracting with more force, and because of the muscle stretching, and the stroke volume has increased. So that increase in stroke volume results in increase of cardiac output, and that is how blood pressure is raised. But when that venous return is decreased, we have a smaller stroke volume. So all of that is reserved. More blood is now in the veins, and so this is how the baroreceptors they help to bring down the blood pressure. So secondly, the baroreceptors they decrease the cardiac output. How do they do it? The impulses to the cardiac center inhibit sympathetic activity and stimulate parasympathetic. So that was their effect on the vasodilator center, on the vasocenter, and it affects the vessels. Now it is affecting the cardiac inhibitory and the cardiac acceleratory centers. And what are they doing? They reduce the heart rate and contractility. And when the heart rate is decreased, the cardiac output it also decreases. So if you look at this diagram, these are the baroreceptors present in the aorta and also in the carotid sinus. So when they think that the blood pressure has increased, they send signals to the medulla. In the medulla we have the cardioinhibitory center and the cardioacceleratory center, and those centers they send signals to the parasympathetic and the sympathetic, and it decreases the heart rate, and then through the vasomotor center it sends to the veins and the arterioles, and the veins dilate and the arterioles also dilate. So this is how they manage the blood pressure. So in this slide it is basically the same thing in a simple way. So baroreceptors, when they are activated due to high blood pressure, they inhibit the cardioacceleratory center and they inhibit the vasomotor center, whereas they stimulate the cardioinhibitory center. So all of these they lead to decreased cardiac output. Now let's go over this figure. So what happens when the blood pressure it increases or decreases, and it is detected by the baroreceptor. The baroreceptor in the carotid sinus and the aortic arch, they are stimulated, and when the blood pressure is low, the baroreceptor in the carotid sinus and the aortic arch, they are inhibited. So the opposite is happening. When the blood pressure is high, they are being stimulated, they are sending more signals, whereas over here they are being inhibited, they are sending less signals. So it means that normally they send some signal which maintains the normal balance, and in this condition they are sending lesser signals. And then what happens? Those impulses from the baroreceptors, they stimulate the cardioinhibitory center, and they inhibit the cardioacceleratory center, and they inhibit the vasomotor center. So the vasomotor center, it affects the vessels, and the cardiac centers, inhibitory and acceleratory, they affect the heart. Similarly, on this side, the opposite happens. Decreased impulses from the baroreceptor, they activate the cardioacceleratory center and inhibit the cardioinhibitory center and stimulate the vasomotor center. And then what happens in this circle? The decreased sympathetic impulses to the heart, they cause decreased heart rate and decreased contractility and decreased cardiac output. Whereas a decreased rate of vasomotor impulses allows the vasodilation, causing decreased resistance. Okay, and and over here the opposite happens, because over here the cardioacceleratory center has been activated and the other two have been and the inhibitory has been inhibited. So over here what happens is that the increased sympathetic impulses to the heart cause increase in heart rate and contractility, and hence the cardiac output is also increased. Whereas vasomotor fibers, they stimulate vasoconstriction, causing increased total peripheral resistance. So when there is vasoconstriction because of the increased vasomotor tone, there is vasoconstriction, and that vasoconstriction results in increasing the total peripheral resistance, and this is also going to increase the blood pressure and bring it back to normal. So this is how the baroreceptors, they are operating to maintain the blood pressure. And in the last part, over here we have increased cardiac output and total peripheral resistance, and the return this returns the blood pressure to homeostatic range. And over here the cardiac output and the resistance are decreased, and this also returns the blood pressure to the homeostatic range. So in short-term neural controls, we have those cardiac centers which we went over, and then we have baroreceptors. Along with baroreceptors, we also have another type of receptors which are known as chemoreceptors. These chemoreceptors, they are also present in the aortic arch and other vessels, and they have the capability of detecting increase in carbon dioxide or a decrease in pH. So increase in carbon dioxide is equal to decrease in pH, because carbon dioxide, it is present in the blood in dissolved form, H2CO3, and H2CO3 is a weak acid. So when carbon dioxide increases, the pH decreases, and there is acidosis. And they also have the ability to detect decrease in the oxygen in the blood. And what do they do? They also send signals to the cardioacceleratory center, and they also send signals to the vasomotor center. And as a result of their signaling, the decreased blood oxygen and increased carbon dioxide and decreased pH, they increase the sympathetic stimulation of the heart, which increases the heart rate and stroke volume. Now, the third factor in the short-term regulation is the higher brain centers. Okay, so so far we said that the short-term neural controls are baroreceptors. They act via baroreceptors, chemoreceptors, and now the third thing is they act via higher brain centers. So reflexes that regulate the blood pressure, they are found in the medulla. Hypothalamus and cerebral cortex can modify arterial pressure via relays to the medulla. And hypothalamus, it increases the blood pressure during stress, and hypothalamus mediates redistribution of blood during exercise and changes in temperature. So hypothalamus, it influences the medulla to maintain the blood pressure, and also it maintains the blood flow to the individual organs. Now let's see how hormones, they affect the short-term regulation or the regulation of the blood pressure. So hormones, they regulate blood pressure in short term via changes in the peripheral resistance, and they can also affect the long term via changes in the blood volume. So in the short term, adrenal medulla, the hormones are the epinephrine and the norepinephrine, and we know they act just like the sympathetic nervous system. So when they are present, the cardiac output will increase and there will be vasoconstriction. Then we have angiotensin 2. Angiotensin 2, it stimulates vasoconstriction. Angiotensin 2, we heard this name before when we were talking about aldosterone. So there was renin-angiotensin-aldosterone mechanism which preserves the water. So this is also through aldosterone. It is increasing the blood volume, and through its direct effect, it is causing the vasoconstriction. So its vasoconstriction role, it is important in the short-term mechanism because it can be done quickly, whereas uh, whereas absorbing the water back into the blood, it takes time. Then we have antidiuretic hormone. Remember, antidiuretic means antidiuresis. It is preventing the body from passing out large amounts of blood and hence getting rid of the water large amounts of urine, and when it stops the production of large amounts of urine, it is actually conserving the water. And the high levels of antidiuretic hormone, they can cause vasoconstriction. And then there is atrial natriuretic peptide. It decreases blood pressure by antagonizing aldosterone, and it causes decreased volume because it is antagonizing aldosterone. And remember, aldosterone, it causes the reabsorption of sodium from the renal tubules, and water follows because water loves sodium. So wherever sodium goes, water comes behind it. So they have summarized these hormones in this table. Let's go over them. Epinephrine and norepinephrine. What is their effect on the blood pressure? It increases the blood pressure. And what are the factors which are affected? Cardiac output through heart rate and contractility. And on the heart, there are beta-1 receptors are present on the heart for the epinephrine and the norepinephrine. And then they also increase the total peripheral resistance, which is known as vasoconstriction, and this happens in the arterioles, and the receptors are the alpha arterioles. So these sympathetic nervous system neurotransmitters like epinephrine and nephrine and epinephrine, there are many different types of receptors, and the response also depends upon the type of the receptor they are going to affect. Then the other hormone is angiotensin 2. Angiotensin 2, it increases the blood pressure and it increases total peripheral resistance by vasoconstriction, especially of the arterioles. Then we have antidiuretic hormone. It also increases the blood pressure and it increases total peripheral resistance, which is known as through vasoconstriction, and it also acts primarily on the arterioles, and it also increases the blood volume because it decreases the water loss. And then we have aldosterone. It also increases blood pressure, it increases blood volume, that is salt and water loss, because like I told you, aldosterone causes the absorption of the sodium from the tubules, and then water also follows the sodium, so it increases the blood volume. And its site of action is the kidney tubule cells, because that is where aldosterone it is acting on, and also the diuretic hormone, it acts on the kidney tubules. Alright, and then atrial natriuretic peptide, it decreases the blood pressure and the blood volume, that is, it decreases the blood volume because of increased salt and water loss, because natriuretic means that it causes the sodium to be present in the urine, and wherever sodium goes, water follows. So sodium and water are both expelled from the body in the urine. So there is salt and water loss, and it also and this section of atrial natriuretic peptide is on the kidney tubules, and then it also decreases the total peripheral resistance, that is direct action on the arterioles. Do go over this chart again. They have put everything together, so if you read it 2 to 3 times, you'll be able to know it better. Now let's come towards the long-term mechanisms. So the long-term mechanism of blood pressure, it is done by the kidneys, the renal regulation. So baroreceptors, they quickly adapt to the chronic high or low blood pressure, so they become ineffective in long-term management of blood pressure. And it is controlled by altering the blood volume through the kidneys. Kidneys regulate arterial blood volume by direct renal mechanism and indirect renal mechanism. So the indirect renal mechanism is renin-angiotensin-aldosterone system. And then there are also some direct renal mechanisms. Let's go over them. So the direct renal mechanism is it alters the blood volume independently of the hormones. Increased blood pressure or blood volume causes elimination of more urine, thus reducing the blood pressure. And decreased blood pressure or blood volume causes kidney to conserve water and the blood pressure rises. So this is how directly the renal system it affects. It alters the blood volume. So this chart, it nicely summarizes the direct renal mechanisms and the indirect renal mechanism. Let's go over it. So when the arterial pressure is low, it means the blood pressure is low. Filtration by the kidneys is low. What is filtration? Filtration is when blood passes through the kidney. Some fluid, it is filtered into the renal tubules this to make into urine. So this is known as filtration in simple words. So when filtration decreases, there is decreased urine formation, and this leads to increased blood volume. Why increased blood volume? Because less water is being removed in the form of urine, and this increased blood volume, it increases the mean arterial pressure. Now let's go over the indirect mechanisms. When there is decreased arterial pressure, it inhibits the baroreceptors, and then there is an increased sympathetic activity. Increased sympathetic activity happens because baroreceptors, they have reduced their input to the center. And now this increased sympathetic nervous system activity, it causes the secretion of the renin released by the kidneys. So this renin, it converts angiotensinogen into angiotensin 1. Then an enzyme known as angiotensin converting enzyme secreted by the lungs, it acts on angiotensin 1 and converts it into angiotensin 2. Now this angiotensin 2 has been made, and what does this do? This angiotensin 2, it stimulates the adrenal cortex, and when adrenal cortex is stimulated, aldosterone is secreted. We know aldosterone is from the outermost layer of the renal cortex. And then when aldosterone is secreted, there is increased sodium reabsorption in the kidneys. And then there is increased reabsorption of water in the kidneys. All right, now let's move on. What happens again? And this leads to so this is, we are going through angiotensin 2. Let's go all over this. So first of all, we spoke about the adrenal cortex, how it is affecting it and how it increased water retention and increased blood volume. Now let's look at the second thing which angiotensin 2 is doing. Angiotensin 2, it increases antidiuretic release by the posterior pituitary. So antidiuretic release from the posterior pituitary, it can be caused by the angiotensin 2. And then what happens, that there is increased water reabsorption by the kidneys, because this is what antidiuretic hormone does. As a result of that volume, it increases. Now let's look at the third mechanism. The third mechanism is angiotensin 2. It stimulates the thirst center in the hypothalamus, and now there is increased water intake, and this also increases the blood volume. Now let's look at the fourth thing it vasoconstricts, and it increases the total peripheral resistance. So it also has a direct effect on the vessel, that it causes vasoconstriction. And we know when there is vasoconstriction, there is increased TPR, and it leads to increased mean arterial pressure. So this is the summary of the direct and the indirect mechanisms. So this slide basically says what I just spoke on that diagram. So the renin angiotensin aldosterone mechanism, what is this? Decreased arterial blood pressure causes release of renin from the kidneys. Renin enters the blood and catalyzes conversion of angiotensinogen from the liver to angiotensin 1. Angiotensin converting enzyme, especially from the lungs, converts angiotensin 1 into angiotensin 2. And then angiotensin 2 acts in four ways to stabilize the blood pressure and the extracellular space. It stimulates the aldosterone secretion. It causes ADH release from the posterior pituitary, and it triggers the hypothalamic thirst center to drink more water, and then it also acts as a potent vasoconstrictor. Okay, so this is again what that you should, it is only here to show you that you must go over it. So what is the goal of blood pressure regulation? The goal of blood pressure regulation is to keep blood pressure high enough to provide adequate tissue perfusion, but not so high that blood vessels are damaged. For example, if blood pressure to brain is too low, perfusion is inadequate and person loses consciousness. If blood pressure to the brain is too high, a person can have a stroke. So both low blood pressure and high blood pressure are not good. We want to keep the blood pressure in the normal range. This chart, it talks about all of the factors which affect the mean arterial pressure. This is present in your Pearson text. You can go over it and it will summarize everything for you which we learned in this slide. Let's quickly go over the clinical side. What will happen if the blood pressure is low or high? So transient elevations in blood pressure occur during changes in the posture, physical exertion, emotional upset, fever, age, sex, weight, race, mood, and posture may also cause blood pressure to vary. And then there is a term hypertension. We are all familiar with it. Sustained elevated arterial pressure of 140 by 90 millimeters of mercury or higher. So 140 by 90 millimeters of mercury or higher is known as hypertension. Then there is pre-hypertension. If values elevated but not yet in hypertension range, maybe transient adaptations during fever, physical exertion, or emotional upset. It can happen due to any of these reasons, and they're often present in the obese people. So people who are on the heavier side, they are more susceptible to have high blood pressure. Prolonged hypertension is a major cause of heart failure, vascular diseases, renal failure, and stroke, because when the blood pressure is high, the heart has to work harder. The myocardium enlarges, but it enlarges, which becomes weakened compared to the normal myocardium. And then with time, it becomes flabby, and then it also accelerates the atherosclerosis. The high blood pressure also accelerates the process of atherosclerosis, which is the formation of plaques in the vessels. Now, hypertension, it can be primary. Primary, it means it is due to the hypertension itself is the disease, or it can be secondary to some other organ. So let's see when it is primary hypertension. 90% of the cases of hypertension are primary hypertension. No underlying cause can be identified, and the risk factors, they include diet, obesity, age, diabetes mellitus, stress, smoking. There is no cure, but it can be controlled. So it is very important that we tell to the patient that now taking hypertension medicine is your normal life. It is your daily routine, because it cannot be cured, but it can be controlled by certain things. And how can they be controlled? It can be controlled by restricting the salt, fat, and the cholesterol intake, by increasing exercise, lose weight, and stop smoking, and then the antihypertensive drugs. So these are the things we can do to control the hypertension. So if there is a term known as primary hypertension, then obviously we have a term which is called secondary hypertension. Secondary hypertension, it is less common. It is due to identifiable orders, including obstructed renal arteries, kidney disease, and endocrine disorders such as hyperthyroidism and Cushing syndrome. All these conditions, they can cause high blood pressure. I will just like to say a few words more about the kidneys, because when the renal arteries, they are obstructed, they think that the blood pressure is low, so they start their mechanism of increasing the blood pressure, and we know they have both direct and indirect mechanisms. So they turn on those mechanisms. Actually what they are trying to do, they are trying to bring the blood pressure back to the normal, but actually the arteries, they are obstructed. Similarly, if there is some renal disease, it can also go the same pathway. And then with the hormones, we know certain hormones, they increase the blood pressure. And what is the treatment? It focuses on treating the underlying cause. Hypertension, it is the blood pressure when it is below 90 over 60 millimeters of mercury. It is usually not a concern unless it causes inadequate blood flow to the tissues. So under the topic of hypotension, I want you to know this term, orthostatic hypotension. Orthostatic hypotension, it is temporary low blood pressure and dizziness when suddenly rising from a sitting or reclining position. Maybe you experienced it sometimes when you are sitting for a long time or you're lying down in your bed and you abruptly at once you get up, you feel lightheaded or dizzy. Why is that? Because of the orthostatic hypotension. There is a momentarily and the body goes into hypertensive phase, and then all the reflexes of the short-term management they kick in and the blood pressure is maintained. And then there is chronic hypotension. Chronic hypotension, it means that the blood pressure is chronically low. It can happen because of poor nutrition, and it can also be a warning sign for the Addison's disease or hypothyroidism. Acute hypotension is important because it is an important sign of circulatory shock. It means that maybe the patient is going towards the circulatory shock, so we have to manage it.